Early onset sepsis strikes within 72 hours of birth, with 90% of affected infants showing symptoms by 24 hours. This timing reflects the pathophysiology, vertical transmission from maternal genital tract flora during labor and delivery. Group B Streptococcus and Escherichia coli dominate as causative organisms, gaining access through ascending infection when protective barriers fail. Incidence patterns show important risk stratification. Overall rates sit at 0.98 per 1,000 live births, but very low birth weight infants face dramatically higher risk at 10.26 per 1,000. This 11-fold increase reflects immature immune systems, compromised skin integrity, and increased exposure to invasive procedures in this vulnerable population. Mortality varies significantly by pathogen, ranging from 10 to 40%. Group B strep typically carries better prognosis, while gram-negative organisms like E. coli demonstrate higher mortality rates, particularly in preterm populations. Early recognition becomes critical since outcomes correlate directly with prompt antimicrobial therapy initiation. Respiratory distress emerges as the predominant presentation, but manifestations often appear subtle initially. A term infant developing progressive tachypnea, grunting, or increased oxygen requirements within hours of delivery warrants immediate evaluation. Temperature instability, apnea episodes, or feeding intolerance frequently accompany respiratory symptoms. The clinical challenge lies in distinguishing early sepsis from normal transitional physiology. While many newborns experience mild respiratory distress during adaptation, persistent or worsening symptoms suggest pathologic processes requiring urgent intervention. Pattern recognition develops through understanding that early-onset sepsis typically presents as respiratory compromise rather than the classic septic appearance seen in later infections. Early-onset sepsis develops through three primary pathways, though ascending infection dominates clinical scenarios. When membranes rupture, protective barriers disappear, allowing maternal genital flora to migrate upward through the cervix and into amniotic fluid. This creates direct fetal exposure through swallowing, aspiration, or skin contact with contaminated fluid. During vaginal delivery, passage through the birth canal exposes the infant to heavy bacterial colonization. Group B, Streptococcus and E. coli, normally residing in maternal genital tract, gain access through mucous membranes, respiratory tract, or microscopic skin breaks. Even brief exposure during crowning can establish significant inoculum. Transplacental transmission remains uncommon, but occurs with specific organisms like Listeria monocytogenes. These pathogens cross placental barriers during maternal bacteremia, establishing fetal infection before delivery. This pathway explains why some infants present with sepsis, despite intact membranes and cesarean delivery. The neonatal immune system lacks the sophisticated responses seen in older children. Neutrophil function remains immature, complement levels stay low, and antibody production is minimal. When bacteria establish infection, this compromised host defense allows rapid multiplication and systemic spread. Cytokine release becomes the critical pathophysiologic trigger. Bacterial endotoxins stimulate massive inflammatory cascade, releasing interleukin-1 and interleukin-6 from various tissue sources, including hair follicles. These inflammatory mediators cause vasodilation, increased capillary permeability, and altered cellular metabolism. Multi-organ dysfunction develops within hours as cytokines disrupt normal physiology. Respiratory distress emerges from pulmonary edema and surfactant dysfunction. Cardiovascular compromise follows from distributive shock and myocardial depression. Metabolic acidosis reflects tissue hypoxia and cellular dysfunction. Early recognition prevents progression to irreversible organ damage, making pattern recognition skills essential for optimal outcomes. The pathogen landscape in early-onset sepsis follows predictable patterns based on gestational age and risk factors. Group B Streptococcus leads among term infants, reflecting maternal colonization rates of 15 to 20% and efficient vertical transmission during vaginal delivery. This gram-positive organism establishes infection through mucosal surfaces and respiratory tract, often presenting with pneumonia and bacteremia. E. coli dominates in preterm and very low birth weight populations, where immature immune systems cannot contain gram-negative invasion. This shift occurs because preterm infants face prolonged hospitalization, invasive procedures, and altered maternal flora from antibiotic exposure. E. coli produces more severe disease with higher mortality rates, particularly when ampicillin resistance emerges. Listeria monocytogenes accounts for approximately 5% of cases, but carries unique significance. This gram-positive rod crosses placental barriers, causing transplacental infection even with intact membranes. Maternal consumption of contaminated foods like soft cheeses or deli meats creates risk, making dietary history relevant during evaluation. Additional gram-negative organisms include Klebsiella, Enterobacter, Citrobacter, and Pseudomonas. These typically emerge in higher-risk scenarios with prolonged rupture of membranes, maternal fever, or previous antibiotic exposure. Each carries distinct resistance patterns that influence empirical antibiotic selection. Staphylococcus aureus and Enterococci represent less common causes, but appear more frequently with invasive procedures or prolonged hospitalization. These organisms suggest nosocomial acquisition rather than typical vertical transmission. The crucial clinical pearl remains that Group B Streptococcus and E. coli together account for 70% of early-onset sepsis cases. This concentration allows focused empirical therapy with ampicillin and gentamicin, covering both organisms while awaiting culture results and susceptibility patterns. Temperature instability provides the most consistent early warning sign in neonatal sepsis, but the pattern defies typical expectations. Hypothermia occurs far more frequently than fever because newborns cannot mount the inflammatory response older children develop. Their immature systems lose heat through vasodilation and metabolic disruption rather than generating the protective fever response we expect with infection. Respiratory distress appears in most septic neonates, manifesting as tachypnea, grunting, and retractions from pulmonary inflammation and surfactant dysfunction. Preterm infants particularly develop apnea episodes as sepsis affects their vulnerable respiratory control centers, sometimes presenting as the only initial symptom. Cardiovascular changes reflect the inflammatory cascade progression. Poor perfusion and delayed capillary refill indicate distributive shock as inflammatory mediators cause widespread vasodilation. Heart rate patterns prove unreliable. Septic infants can present with either compensatory tachycardia or concerning bradycardia from myocardial depression. Beyond these system-specific findings, non-specific signs often provide the earliest clues. Feeding intolerance, lethargy, irritability, or subtle changes in muscle tone frequently precede obvious vital sign abnormalities. Abdominal distension, vomiting, or altered sleep patterns may represent the only initial manifestations. The most valuable diagnostic tool remains clinical intuition. When experienced caregivers report an infant is not acting right, this subjective assessment carries tremendous diagnostic weight. These subtle behavioral changes often represent the earliest recognition of developing sepsis, appearing hours before laboratory abnormalities or vital sign changes become apparent. Neurologic manifestations of early-onset sepsis reveal how bacterial toxins and inflammatory mediators directly affect the developing brain. Lethargy and poor muscle tone develop as cytokines cross the blood-brain barrier, disrupting normal neural function. The floppy, listless appearance contrasts sharply with typical neonatal alertness and muscle tone, making this combination particularly concerning. Paradoxically, some septic infants present with irritability instead of lethargy. This represents neurologic hyperexcitability from inflammatory mediators affecting nerve transmission. These babies appear restless, difficult to console, and overreact to normal stimuli like routine care or gentle touch. Cry quality changes provide another neurologic clue. A weak cry suggests decreased neurologic drive and muscle weakness, while high-pitched crying indicates increased intracranial pressure or meningeal irritation. Both patterns differ significantly from the robust, lusty cry of healthy newborns and warrant immediate evaluation. Poor feeding encompasses multiple neurologic functions. Sepsis disrupts the coordinated suck-swallow-breathe sequence, reduces oral motor strength, and decreases the neurologic drive to feed. This often appears as the earliest subtle sign before other symptoms develop. Gastrointestinal manifestations reflect how sepsis disrupts normal motility and absorption. Feeding intolerance with increased gastric residuals suggests decreased gut motility from inflammatory mediators affecting enteric nervous system function. Abdominal distension follows as normal peristalsis slows and gas accumulates. Vomiting and diarrhea represent more advanced gastrointestinal involvement, indicating significant systemic illness. These symptoms often accompany electrolyte imbalances and dehydration, compounding the clinical deterioration. Skin findings remain less common, but highly specific when present. Modeling reflects poor peripheral circulation from distributive shock, while petechiae suggest platelet consumption or dysfunction from disseminated intravascular coagulation. Pneumonia represents the most common manifestation of early-onset sepsis, affecting up to 70% of septic neonates. Understanding the distinction between early-onset and congenital pneumonia helps clarify timing and pathogenesis. Early-onset pneumonia develops during labor and delivery through the ascending infection pathway we've discussed. Bacteria migrate through ruptured membranes or gain access during passage through the birth canal, establishing pulmonary infection within hours of birth. Group B Streptococcus, E. coli, and Listeria represent the predominant organisms using this route. Congenital pneumonia occurs through in utero acquisition, typically via transplacental spread during maternal bacteremia. Listeria monocytogenes particularly favors this pathway, crossing placental barriers and establishing fetal infection before delivery. These infants may present with respiratory distress immediately at birth, even with cesarean delivery and intact membranes. The clinical challenge lies in distinguishing septic pneumonia from common transitional disorders. Respiratory distress syndrome and transient tachypnea of the newborn produce similar initial presentations: tachypnea, grunting, and retractions. However, septic pneumonia typically causes hypoxemia that seems disproportionate to the degree of respiratory distress observed. Think of a late preterm infant requiring unexpectedly high oxygen concentrations despite relatively mild retractions, or a term baby developing progressive hypoxemia when transient tachypnea should be resolving. This oxygen requirement disproportion raises suspicion for infectious etiology rather than mechanical or fluid-related causes. Chest radiograph findings prove frustratingly variable in neonatal pneumonia. Some infants show classic consolidation patterns, while others display only subtle increased markings or appear completely normal initially. The absence of radiographic abnormalities never excludes pneumonia in symptomatic neonates, making clinical assessment paramount over imaging findings. Congenital pneumonia develops before birth when infectious organisms reach the fetal lungs through three distinct mechanisms. The pathogenesis differs from early-onset pneumonia we just discussed, though clinical presentations often overlap significantly. Aspiration of infected amniotic fluid represents the most common pathway. When chorioamnionitis develops, bacteria multiply within amniotic fluid, and normal fetal breathing movements introduce contaminated fluid directly into developing lungs. This creates established infection before delivery begins, explaining why some infants present with immediate respiratory distress despite intact membranes or cesarean delivery. Hematogenous spread occurs when maternal bacteremia seeds fetal circulation through placental blood flow. Organisms like Listeria monocytogenes particularly favor this route, establishing systemic infection that includes pulmonary involvement. These cases often present with multi-organ manifestations beyond isolated pneumonia. Direct extension from chorioamnionitis represents local spread from infected membranes and placental tissues. Ascending bacteria establish placental infection, then migrate directly into fetal tissues, including lung parenchyma. This mechanism typically accompanies prolonged membrane rupture and maternal fever. Chest radiograph findings in congenital pneumonia show characteristic patterns that help distinguish infectious from developmental causes. Diffuse bilateral infiltrates create a ground glass appearance throughout both lung fields, reflecting widespread inflammatory changes rather than localized consolidation. Air bronchograms appear as dark tubular structures outlined against opaque lung tissue, indicating patent airways surrounded by consolidated alveoli. Pleural effusions occur rarely, but suggest severe infection with significant inflammatory response. When present, they support infectious etiology over developmental disorders. The diagnostic challenge emerges because congenital pneumonia closely mimics respiratory distress syndrome radiographically and clinically. Both conditions produce bilateral infiltrates, air bronchograms, and immediate respiratory distress in preterm infants. Distinguishing between these entities requires integrating maternal risk factors, clinical course, and response to treatment rather than relying solely on imaging findings. Without prompt antibiotic therapy, congenital pneumonia carries mortality rates approaching 60%. Early recognition and treatment dramatically improve outcomes, making empirical antibiotics appropriate whenever clinical suspicion exists. Blood culture represents the definitive diagnostic gold standard for early-onset sepsis, providing both organism identification and antibiotic susceptibility patterns crucial for targeted therapy. However, obtaining adequate sample volume poses the greatest technical challenge in neonates. The minimum 1 milliliter requirement often seems substantial when drawing from fragile infant veins, but insufficient volume dramatically reduces detection sensitivity, potentially missing low-grade bacteremia that still requires treatment. Complete blood count patterns provide supportive evidence but require careful interpretation within developmental context. White blood cell counts outside normal ranges, below 5,000 or above 30,000, suggest immune system activation or depression. However, normal counts never exclude sepsis, particularly in early stages before hematologic changes develop. The immature to total neutrophil ratio becomes more useful than absolute counts in neonates. Ratios exceeding 0.2 indicate immature neutrophil release from bone marrow, reflecting systemic stress and immune activation. This represents early mobilization of infection-fighting cells before absolute counts change significantly. Absolute neutrophil count below 1,500 suggests neutropenia from either consumption during active infection or bone marrow suppression from overwhelming sepsis. This finding carries concerning implications because adequate neutrophil numbers are essential for effective bacterial clearance. C-reactive protein offers limited utility in early sepsis evaluation because this acute phase reactant requires 12 to 24 hours to rise significantly after bacterial exposure. Since early-onset sepsis demands immediate antibiotic initiation, normal CRP values within the first day cannot exclude infection. Lumbar puncture becomes necessary when clinical presentation suggests central nervous system involvement, altered mental status, seizures, or neurologic abnormalities beyond typical septic lethargy. The procedure carries higher risks in unstable neonates, requiring careful risk-benefit assessment. Chest radiography proves essential when respiratory symptoms predominate, helping distinguish infectious pneumonia from developmental disorders like respiratory distress syndrome or transient tachypnea. However, normal chest films never exclude pneumonia in symptomatic infants. Notably, urine cultures play no role in early-onset sepsis evaluation because ascending urinary tract infection rarely occurs within 72 hours of birth. Renal seeding from bacteremia remains uncommon in this time frame, making urine collection unnecessary and potentially delaying more critical interventions. Interpreting the complete blood count in suspected early-onset sepsis requires understanding how normal neonatal hematologic values differ dramatically from older children and adults. The developing immune system produces characteristic patterns that change hour by hour during the first days of life. Total white blood cell count interpretation depends critically on postnatal age. A count of 15,000 might seem elevated in an adult, but represents normal physiologic stress response in a newborn during the first 24 hours. The concerning thresholds below 5,000 or above 30,000 indicate either immune system depression from overwhelming infection or excessive activation from bacterial invasion. The immature to total neutrophil ratio provides more sensitive early detection than absolute counts. This calculation divides bands and metamyelocytes by the total neutrophil population, revealing bone marrow response to infection before total counts change significantly. Normal ratios stay below 0.1 in healthy neonates. When ratios reach 0.2, this suggests early bacterial challenge triggering immature cell release. Ratios approaching 0.4 indicate severe infection with massive bone marrow mobilization, representing high-risk scenarios requiring immediate aggressive intervention. Understanding the pathophysiology helps interpret these patterns. During bacterial invasion, Mature neutrophils migrate from circulation to infection sites, creating relative depletion in peripheral blood. Bone marrow responds by releasing immature forms, bands, and metamyelocytes to maintain circulating numbers. This left shift creates elevated immature to total ratios before total counts drop significantly. Absolute neutrophil count patterns reveal immune system adequacy. Counts below 1,000 indicate high infection risk because adequate neutrophil numbers are essential for effective bacterial clearance. When counts fall below 500, severe neutropenia creates extremely vulnerable conditions where even normal flora can establish life-threatening infections. Platelet counts below 100,000 suggest consumption from disseminated intravascular coagulation or direct bone marrow suppression. While bacterial sepsis can produce thrombocytopenia, severe drops often indicate fungal infection, particularly in preterm infants with prolonged hospitalization or multiple invasive procedures. The key clinical principle involves integrating these laboratory findings with clinical presentation rather than relying on isolated values. A mildly elevated immature to total ratio in an asymptomatic term infant carries different implications than the same ratio in a preterm baby with respiratory distress and temperature instability. Acute phase reactants like C-reactive protein and procalcitonin provide valuable diagnostic information, but understanding their kinetics prevents misinterpretation that could delay appropriate treatment in neonatal sepsis. C-reactive protein follows a predictable inflammatory response timeline that explains its limited utility in early sepsis evaluation. This hepatically synthesized protein requires significant stimulus and time to rise meaningfully, typically 6 to 12 hours after bacterial invasion begins. Peak concentrations occur 24 to 48 hours later, making CRP essentially useless during the critical window when clinicians must decide whether to initiate antibiotics. The diagnostic strength of CRP lies in its negative predictive value rather than early detection capability. Serial measurements over time provide much more information than single values. An infant presenting with respiratory distress and normal CRP at 4 hours of age cannot have infection ruled out, but persistently normal CRP values over 48 to 72 hours with clinical improvement suggest non-infectious etiology. Procalcitonin represents a more sophisticated inflammatory marker with faster kinetics and better bacterial specificity. This calcitonin precursor rises within 2 to 4 hours of bacterial infection, providing earlier detection than C-ARP. Additionally, procalcitonin shows greater specificity for bacterial versus viral infections, theoretically improving diagnostic precision. However, procalcitonin interpretation in neonates faces significant physiologic limitations. Normal newborns experience dramatic procalcitonin elevation during the first 48 hours of life as part of normal transition physiology. This physiologic surge can reach levels typically associated with severe bacterial infection in older children, creating diagnostic confusion precisely when early-onset sepsis risk peaks. The clinical reality dictates that neither marker should influence immediate treatment decisions in suspected early-onset sepsis. When clinical presentation suggests infection within 72 hours of birth, empirical antibiotics must begin before inflammatory markers can provide reliable information. These laboratory values serve better for monitoring treatment response, guiding antibiotic duration, and supporting decisions to discontinue therapy rather than initial diagnostic confirmation. Understanding these limitations prevents dangerous delays in treatment while acknowledging the supportive role these markers play in comprehensive sepsis evaluation and management decisions. Group B streptococcus risk stratification provides a systematic framework for making critical decisions about neonatal management in the first hours after delivery. This evidence-based approach balances infection prevention against unnecessary antibiotic exposure, recognizing that most colonized infants never develop disease. High-risk scenarios mandate treating the infant as though infection has occurred, rather than simply monitoring for symptoms. Inadequate intrapartum antibiotic prophylaxis, defined as less than 4 hours between antibiotic administration and delivery, leaves insufficient time for maternal antibiotic levels to suppress vertical transmission effectively. The 4-hour threshold reflects pharmacokinetic studies showing optimal fetal tissue penetration requires this minimum duration. Maternal fever during labor creates a high-risk situation regardless of antibiotic prophylaxis adequacy. Temperature elevation suggests chorioamnionitis, indicating bacterial invasion has already occurred within the amniotic cavity. This transforms the clinical scenario from prevention to active treatment of established infection. The fever threshold typically uses 100.4 degrees Fahrenheit or 38 degrees Celsius as the cutoff, though any significant temperature elevation warrants concern. Prolonged rupture of membranes exceeding 18 hours eliminates the protective barrier between maternal flora and fetal environment. This duration represents the evidence-based inflection point, where ascending infection risk increases dramatically. Even with adequate antibiotic prophylaxis, prolonged membrane rupture creates ongoing exposure that overwhelms preventive measures. Low-risk infants receive observation rather than empirical treatment when maternal antibiotic prophylaxis was adequate and no additional risk factors exist. These newborns undergo enhanced monitoring for signs of infection but avoid unnecessary antibiotic exposure. This approach recognizes that the vast majority of these infants will remain healthy while maintaining vigilance for the small percentage who might develop disease. Unknown maternal GBS status creates decision-making complexity that requires integrating available risk factors. When any concerning elements exist, fever, prolonged rupture, inadequate prophylaxis timing, the unknown colonization status defaults to treating as though positive. However, term well-appearing infants born to mothers with unknown GBS status but no other risk factors can undergo careful observation rather than empirical treatment. This stratification system exemplifies evidence-based medicine translating complex epidemiologic data into practical bedside decisions that optimize outcomes while minimizing unnecessary interventions. E. coli represents a distinctly different challenge in early-onset sepsis compared to the Group B streptococcus we just discussed. As a gram-negative rod, this organism possesses fundamentally different structural characteristics that directly influence its pathogenicity and clinical management requirements. The epidemiologic pattern shows E. coli's particular affinity for vulnerable populations. While GBS predominates in term infants, E. coli emerges as the leading cause of early-onset sepsis in preterm and very low birth weight babies. This shift occurs because these infants face prolonged hospitalization, invasive procedures, and exposure to broad-spectrum antibiotics that alter normal maternal flora composition. The association with chorioamnionitis reveals important pathophysiologic differences. E. coli demonstrates enhanced ability to establish intraamniotic infection, creating the inflammatory cascade that leads to preterm labor. This creates a vicious cycle, where chorioamnionitis triggers preterm delivery, and preterm infants face increased susceptibility to the same organism causing their premature birth. Understanding capsular serotypes becomes critical when E. coli causes central nervous system invasion. Strains possessing the K1 capsule show remarkable neurotropism, accounting for approximately 80% of E. coli meningitis cases. This polysaccharide capsule mimics human neural cell adhesion molecules, allowing organisms to cross the blood-brain barrier efficiently and establish meningeal infection. The therapeutic challenge emerges from increasing ampicillin resistance, now approaching 30 to 40% of E. coli isolates. This resistance pattern fundamentally alters empirical antibiotic selection, explaining why gentamicin becomes essential in combination therapy. Unlike GBS, which remains universally ampicillin sensitive, E. coli requires broader antimicrobial coverage from the outset. Mortality rates consistently exceed those seen with GBS infection, reflecting E. coli's enhanced virulence and resistance patterns. When meningitis develops, outcomes become particularly concerning because gram-negative organisms produce more severe neuroinflammation and tissue damage than gram-positive bacteria. The clinical pearl involves recognizing E. coli's increased likelihood in infants whose mothers received intrapartum antibiotic prophylaxis. While this intervention effectively prevents GBS disease, it can alter maternal flora and potentially increase gram-negative organism exposure, making E. coli coverage essential in these scenarios. Listeria monocytogenes presents a unique pathogenic profile that sets it apart from other early-onset sepsis organisms through both its transmission patterns and devastating clinical manifestations. Understanding this gram-positive rod requires appreciating how its distinctive cellular characteristics enable unprecedented virulence. The tumbling motility represents Listeria's diagnostic signature under microscopic examination. Unlike other bacteria that move in linear patterns, Listeria exhibits characteristic end-over-end rotation that creates its pathognomonic tumbling appearance. This unique movement pattern aids laboratory identification and reflects specialized flagellar arrangement that contributes to tissue invasion capabilities. Transmission pathways reveal why Listeria poses such clinical challenges. Unlike Group B, Streptococcus, and E. coli, which primarily use ascending infection routes, Listeria demonstrates remarkable ability to cross placental barriers during maternal bacteremia. This transplacental transmission creates established fetal infection before delivery begins, explaining why some infants present with overwhelming sepsis despite cesarean delivery and intact membranes. Additionally, traditional birth canal transmission occurs during vaginal delivery, creating dual exposure risks. The epidemiologic connection to contaminated foods makes Listeria particularly insidious. Maternal consumption of deli meats, soft cheeses, smoked fish, or unpasteurized dairy products creates bacteremia that seeds fetal circulation. The organism's ability to multiply at refrigeration temperatures means properly stored foods can still harbor dangerous bacterial loads. When maternal infection develops, it often manifests as subtle flu-like symptoms that may not prompt medical attention, allowing fetal transmission to occur unrecognized. Early-onset listeriosis produces two distinct clinical syndromes. Granulomatosis infantiseptica represents the most severe form, characterized by widespread granulomatous inflammation affecting multiple organ systems. These infants present with disseminated abscesses throughout liver, spleen, lungs, and brain, creating the characteristic granulomatous lesions that give this syndrome its name. The mortality rate of 20 to 30% reflects Listeria's exceptional virulence and ability to establish rapidly progressive multi-organ infection. Unlike other bacterial pathogens that primarily cause localized infection with secondary bloodstream invasion, Listeria creates primary disseminated disease from the outset. Treatment requires ampicillin as the cornerstone antibiotic, often combined with gentamicin for synergistic bactericidal activity. This combination becomes essential because Listeria demonstrates intrinsic resistance to many antibiotics effective against other gram-positive organisms, making targeted therapy crucial for optimal outcomes. Group B Streptococcus represents a fascinating example of how bacterial structure directly correlates with pathogenicity and clinical outcomes. This gram-positive organism arranges itself as diplococci within characteristic chains, creating the distinctive microscopic pattern pathologists recognize on gram stains from infected neonatal specimens. The 10 distinct serotypes reflect variations in surface capsular polysaccharides, but clinical practice focuses on the most medically relevant strains. Serotypes 1A, 1B, 2, 3, and 5 account for the vast majority of neonatal disease. Understanding serotype distribution matters because type 3 demonstrates particular neurotropism, showing strong association with meningitis and late-onset sepsis. This serotype possesses enhanced ability to cross the blood-brain barrier, explaining why GBS meningitis often involves type 3 strains. Maternal colonization patterns reveal the epidemiologic foundation of neonatal disease. Between 10 and 30% of pregnant women carry GBS in their genital tract, usually asymptomatically. This colonization represents normal flora rather than active infection, but creates the reservoir for vertical transmission during delivery. The transmission and disease progression follows predictable patterns that explain screening and prevention strategies. Among colonized mothers, approximately 50% transmit organisms to their infants during vaginal delivery. However, colonization does not equal disease. Only 1 to 2% of colonized neonates actually develop symptomatic infection. This progression from maternal colonization to neonatal colonization to clinical disease represents multiple host and bacterial factors interacting. The polysaccharide capsule functions as GBS's primary virulence factor, providing protection against host immune responses. This capsule inhibits complement activation and phagocytosis, allowing organisms to persist and multiply in bloodstream and tissues. Different serotypes produce chemically distinct capsules, explaining variations in tissue tropism and clinical presentations. Universal maternal screening between 35 and 37 weeks gestation, combined with intrapartum antibiotic prophylaxis for positive cultures, has created one of pediatrics' greatest prevention success stories. This strategy has reduced early-onset GBS disease incidence by approximately 80% since implementation, demonstrating how understanding bacterial pathogenesis translates into effective clinical interventions. Early-onset sepsis treatment demands immediate action because bacterial multiplication and toxin production occur exponentially once infection establishes. The principle, start empirically, don't delay, reflects decades of clinical experience showing that mortality increases dramatically with each hour of delayed antibiotic administration. When clinical suspicion exists, treatment begins while diagnostic workup proceeds simultaneously. The standard combination of ampicillin plus gentamicin represents rational empirical therapy based on epidemiologic data we've reviewed. This pairing provides optimal coverage for the three major early-onset pathogens: Group B Streptococcus, E. coli, and Listeria monocytogenes. Ampicillin targets gram-positive organisms like GBS and Listeria, while gentamicin covers gram-negative organisms like E. coli that may demonstrate ampicillin resistance. Understanding the synergistic mechanism explains why combination therapy surpasses single-agent treatment. Ampicillin disrupts bacterial cell wall synthesis, creating pores that enhance gentamicin penetration into bacterial cytoplasm. This cooperative effect produces bactericidal activity greater than either antibiotic achieves alone, particularly important against organisms like Listeria and Enterococci, where synergy becomes essential for clinical cure. Ampicillin dosing follows age-based pharmacokinetic principles that reflect neonatal renal and hepatic maturation. During the first week of life, immature kidney function requires extended dosing intervals. 50 milligrams per kilogram every 12 hours provides adequate tissue concentrations while preventing accumulation. When meningitis develops, dosing increases to 100 milligrams per kilogram every 8 hours because central nervous system penetration requires higher serum concentrations to achieve therapeutic cerebrospinal fluid levels. Gentamicin dosing complexity reflects gestational age-dependent pharmacokinetics. Preterm infants demonstrate prolonged drug elimination requiring extended intervals between doses, while term infants clear gentamicin more efficiently. This gestational age-based dosing prevents both inadequate therapy and nephrotoxicity from drug accumulation. Cefotaxime consideration arises when meningitis becomes suspected or confirmed. This third-generation cephalosporin provides excellent central nervous system penetration and broad gram-negative coverage without the nephrotoxic concerns associated with gentamicin. The decision involves balancing enhanced CNS activity against potential selection pressure for resistant organisms in intensive care environments. Antibiotic duration decisions in early-onset sepsis require balancing infection clearance against unnecessary antibiotic exposure, with culture results and clinical response providing the primary guidance for these critical timing decisions. When blood cultures remain negative after 48 hours of incubation and infants appear clinically well, discontinuing antibiotics at 36 to 48 hours represents standard practice. This approach recognizes that significant bacterial growth typically appears within 24 to 48 hours in modern blood culture systems. Negative cultures combined with clinical stability suggest either no infection was present or that empirical therapy successfully prevented progression of early bacterial inoculation. The challenge emerges with culture-negative but symptomatic infants, where clinical judgment becomes paramount. These scenarios might represent viral infections, non-infectious inflammatory conditions, or bacterial infections with inadequate culture sampling. When respiratory distress persists, temperature instability continues, or feeding difficulties remain unexplained, extending therapy to 5 to 7 days provides reasonable coverage while monitoring clinical evolution. This duration allows time for alternative diagnoses to emerge while ensuring adequate treatment if low-grade bacterial infection was present. Culture-positive cases follow more definitive guidelines based on infection site and organism characteristics. Bacteremia and pneumonia typically require 10 days of therapy to ensure complete bacterial eradication and prevent relapse. This duration reflects clinical trial data showing optimal outcomes with this treatment length across various neonatal pathogens. Meningitis demands extended therapy lasting 14 to 21 days because of the unique challenges posed by central nervous system infection. The blood-brain barrier limits antibiotic penetration, requiring prolonged treatment to achieve bacterial sterilization within cerebrospinal fluid compartments. Additionally, the devastating consequences of treatment failure in meningitis justify extended therapy despite increased antibiotic exposure risks. The key clinical principle involves individualizing decisions based on pathogen virulence, infection site, clinical response, and ongoing risk factors rather than following rigid protocols. An infant with Group B Streptococcus bacteremia, who demonstrates rapid clinical improvement, might complete therapy at 10 days, while the same organism causing meningitis in a preterm infant might require 21 days for optimal outcomes.